I'm Barbara Passman. I'm a senior clinical social worker here at University of Chicago. I have been here many, many years, and I trained in social work at the University of Chicago, was fortunate to have an internship here, and was invited to stay on, and I've been pleased to be here. It's been over 30 years. The University of Chicago, the education, first of all, in graduate school, is one of the top graduate schools in clinical social work. And I fell in love with the academic environment. I fell in love with the interest in research, the thirst for knowledge, and the collegiality. People work together here. As we became a multidisciplinary team, as our breast center, the engagement of many, many disciplines evolved, which it did over the last 15, 20 years, I just stayed along. It became an integral part of it. Why am I a social worker? Why am I a medical social worker? Very simple. I like working with people. I like being able to assist, but as a social worker, as opposed to some of the other mental health or other helping professions, we focus holistically. We focus not only on the problems, the issues, the weaknesses, but we look for the strengths. We look for ways to empower people to help themselves. I'm not a physician, I'm not a doc, I'm not a nurse, but I can fit in the interstices and help patients feel comfortable in a complex medical center, help them acknowledge to themselves their questions, their fears, help them learn how to communicate in a complex medical world, which this is. A patient who comes here sees so many clinicians, so many white coats, that probably for most people it's overwhelming and overpowering. And while everybody reaches out, everybody is warm and engaging, there are very few people who think about what the patient really must be feeling like, waiting in line, not knowing which room to go to, not even always knowing which white coat is whom, feeling embarrassed about raising certain questions. And I'm a person that helps or tries to help. My goal is to work with patients so that when they come in, they feel they're equal partners on the team. Their strengths, their knowledge, their courage is emphasized and brought to the other team members, and they're helped to raise the questions, possibly refute some of the information they're given. They're allowed to communicate and dialogue with their physicians. And teaching patients how to do that is part of what medical social work is about, and that's what I'm able to do here. Nowadays, breast cancer treatment, it's so advanced. It, in a way, has gotten more democratic. Patients, as you know, women now are very much involved in choices, where before they often went to the hospital, signed the dotted line, and they woke up and a breast was gone and they didn't really know what was going to happen. Now it's more democratic. Everybody talks to patients. We get their input, and there are more choices. It's actually gotten more difficult in many ways for ladies, or it's seemingly difficult. Complicated, a lengthier process, more choices for them to make, coupled with the fact that it all occurs at a rapid pace, a blur. It's get the information, start going through a whirlwind of testing, and suddenly come in and you're out the next day after you've had a surgical procedure, or you're home the same day. And because of that, for all the value, and we applaud the fact now that things are more democratized, we have more choices, it's made it harder for ladies. There's no time to even deal with their emotions, to ask the questions, to do all of and there are many sociological, there are family adjustments, financial adjustments, crying, getting that out. There's no time for that anymore. So the social worker, a warm, empathetic, psychologically attuned nurse or doctor become even more important now, not less important. And that's why my role has remained and even increased in relevance to working with our patients. Listening, talking, asking them questions and listening to their answers. I try to focus on each page. They come in, they're very worried, and they have all these questions they want to ask the doctor. And one of the things I do is slow down and talk to them about themselves. And it may seem like simple chit-chat, but I'm always curious about who they are, what they do, who they are when they're not in the hospital. I do get involved. I rely heavily on the clinicians and the nursing staff they are excellent working with patients, but because of the pressures of their time, they often will realize they can't stay with the patient and ask me to come in. And then it's really the same thing. By that time, the patient's heard something that they either are frightened about or the opposite. We get a sense that they're not hearing. And I just again engage and ask it's the same approach. It's how are you? How are you doing? What's today like for you? What's going on? What do you want? Is there anything you want to say to me? I know you've been working with the doctors. They've been talking to you. Can you capture for me what have you understood from what they said? What does it mean to you? Where do you think you'll be going from here? What can we do to help? Etc. etc. It's not a script. It's just really taking the cues from the ladies, from the patients and their families that are with them. Some people love groups, others don't. And I present it, as do the nurses do too, we all do, and we leave it up to the patient. We just try to encourage and explain so they feel comfortable again with the idea, don't feel intimidated. But it's very individual how people get support. Some will call myself or the doctor's nurses. We are the chief support. Others will go to family members. Other people will use their pastor, their neighbor, and others will use the official support groups or the well-known helplines from organizations like YME or the American Cancer Society. These patients often call me. Their families call. They know now there are social workers, and the call comes into our department and it gets routed to me. The doctor's nurse may call me. The surgeon herself or himself may call me. I can see the patients right after surgery, the day after. I may see them when they come back to clinic. It just depends when either the patient says something that triggers the social worker or my other medical colleagues realize there's a reason that I might be helpful. So again, it's very variable. Prior to surgery, day of surgery, I've worked a lot with family members while they're waiting, biting their nails in the waiting room. I've seen patients afterwards. It's just very variable. It's what the patient needs is what counts.